Good afternoon, everyone. I'm glad to have folks join us for a discussion of some of the key takeaways from the Omnibus bill that President Biden signed at the end of December 2022. It was a very good bill for mental health care and for telehealth care, and very timely with a number of things going on in our country. So I want to talk just about some of the bill's key components and their impact on mental health and substance use disorder treatment, and then drill down on a couple of areas that I think are particularly important to watch as they unfold in terms of legislation and how certain bills are interpreted by the medical community. Let's first remember that as of the airing of this presentation, the public health emergency started January 31st of 2020. So we're almost 3 years fully in. And it's been renewed every 90 days since it began. So 3 years. There was anticipation that maybe it would end this January, but it does look like it's likely going to officially end as a public health emergency in April. So it's estimated to be about April 11th of 2023. There was a lot of concern about what would happen at that point. It was often called the cliff that patients would fall off of in terms of telehealth legislation that had enabled patients to get care that they needed and for providers to offer that care through telehealth strategies, that would just abruptly end, which would really be horrible for those of us who have either been on the receiving or giving end of telehealth. So we're very grateful for the Omnibus bill. This bill was originally called the Consolidated Appropriations Bill or Act of 2022, and that was going to extend by 151 days all the current telehealth regulations and flexibilities that are in place now. It's going to extend them for 151 days after the end of the public health emergency. So if it ended in April 11th, that would extend it to September 11th of 2023. This new omnibus spending package, or it goes by other names, House Resolution 2617, or the Performance Enhancement Reform Act, or the Consolidated Appropriations Act of 2023, all these different names. We'll just call it the Omnibus Bill. That has allocated $1.7 trillion to multiple areas of discretionary spending in our government, which is pretty extraordinary. It does a lot of other things too. It extends the public health emergency era flexibilities to the end of 2024. So that's 2 years. So we have 2 years to work on telehealth legislation and get things more secure. And I'm going to talk about some of the specifics of that. During these next 2 years, Congress will continue to review claims coming in through Medicare and Medicaid services, CMS. They're going to be looking at the types of services that are offered, where they are being offered, who's providing them, where the patient's located, and how long those services are needed for. So a lot of data is going to be gathered. The hope being for us in the telehealth industry that during this 2-year period and going forward, the whole telehealth industry will coalesce around some core features of how healthcare is provided. I'm really excited about it because I think at Iris, we've been doing telehealth for over 10 years and have seen the impact that telebehavioral health, telemental health has on communities around the country where access is very limited. So I'm really excited about this extension for 2 more years and about the dozens of bills that are at the state and federal level to make many of the flexibilities permanent law for how healthcare is delivered. Talk about a couple of things. The funding expansion in the Omnibus bill includes $7.5 billion for SAMHSA. And SAMHSA is the Substance Abuse Mental Health Services Administration. So they oversee essentially spending on mental health and substance use disorder care. Wonderful things are being funded through that $7.5 billion from SAMHSA. Those include mental health block grants for screening, prevention, and treatment of mental health and substance use disorders. The CCBHC model, the Certified Community Behavioral Health Clinic model expansion, which is great for accountability for organizations that are doing behavioral health and how they measure and provide services. expansion of children's mental health services and school-based resources, more money put into suicide prevention and behavioral health and crisis prevention, including the 988 hotline, which has been fantastic. It needs to continue to run and be serviced and monitored. Also, additional dollars for mental health crisis response grants. So a lot of things at the community level. Some other things that are also really important parts that most people might not think of. There's funding to increase 200 more slots for residency and fellowship training. And half of those 200 slots are for psychiatry and fellowships related to psychiatry. So that's a big win for those that are thinking about going into psychiatry as a field, which is a wonderful field. Expansion of services by other services through telehealth, including physical therapy, occupational therapy, speech and language therapy, audiology. All those things are going to continue to be funded through telehealth, which is really important. And also in medicine, it involves a lot of training and supervision of trainees. So trainees are going to be allowed to continue to be supervised through direct supervision through telehealth or telemedicine initiatives. So that's continues a lot of things that we've become accustomed to during the public health emergency. In terms of telehealth and the provision of telehealth in behavioral health, so related to mental health and substance use disorder treatments, two areas that I want to point out. I mean, there's lots of things we could talk about, but two main categories that I want to talk about are geography and regulatory areas. Let's talk about geography first. What this omnibus bill does for the next 2 years is offers a temporary suspension, continued suspension of the geographic site requirements for providing care. So historically in medicine, you had to go drive usually to a clinic, to a hospital, to a facility to get care, because that's a site of care. And you could only get care there. Your doctors and nurses and others that are providing care could only get reimbursed if the patient went there. So this change to taking away the site requirement is huge. For much of my practice life, many patients that are in rural areas still did not qualify to get telehealth in their areas because they weren't within these strict geographic areas of care. So that's a huge change, a huge win for telehealth and for patients that need telehealth. Also, not allowing the linkage of telehealth care only to designated healthcare shortage areas, because we used to talk about doing telehealth in healthcare shortage areas. That's really important, but in the public health emergency, every place was designated a healthcare shortage area, which really is the truth. Our country is in need of behavioral health care. It's in short supply. So I don't know that there's a lot of going back to seeing it any other way, but those are some important geographic provisions. Also allowing FQHCs and rural healthcare clinics, so federally qualified healthcare clinics and rural healthcare clinics, to remain eligible for telehealth services is really important. Many of them could not get telehealth reimbursement particularly for mental health services. So at IRIS, we've partnered with dozens and dozens of FQHCs and rural health clinics across the country. They're often in areas of real shortage, real need, where mental health access is important. And so those FQHCs and rural health clinics will be able to remain eligible for those services. And it's interesting, this is the language of things. It doesn't apply to telehealth per se, but it is allowed and for reimbursement in care under interactive real-time telecommunications technology. That's what it's called instead of telehealth. So it's still allowed. It's still like telehealth. It's called something different. But that's really exciting. And we love partnering with rural health clinics that are providing both physical and behavioral health and substance use disorder treatment. So that's wonderful. Another provision geographically is allowing the patient's home or domicile, if they live in a homeless shelter or some type of recovery center, that home or domicile will remain an eligible healthcare site, so people can get care in their homes. Now, there's certain requirements around that that are going to be teased out a little bit more, and we'll talk about that in a minute. Also, audio-only services. That was really key in the early days of the pandemic. And for folks that didn't have the bandwidth or data plans to do a lot of video interviews, to be able to see those patients through audio only, particularly for substance use disorder treatments and prescribing buprenorphine and life-saving treatments, doing it through audio only was really important. Now, as a doc, I'm not used to just talking to my patients on the phone a lot, so it's kind of different, and the use of it has gone down, but it's still really critical for many, many patients in rural areas that don't have bandwidth or coverage plans. To be able to call them and talk to them on the phone and keep them well, keep them in treatment, keep them engaged with their therapists and other services is going to be really important. What's going to be required of that is that doctors and patients have to determine that audio only services or telehealth services are going to be critically necessary to them getting care and staying well. And I think as providers, we're going to need to better document in our notes why we're doing telehealth, that it's not just out of convenience for me or for the patient. It's because the patient and the healthcare provider agree that telehealth, either through video or audio, is critical to them getting the care that they need to stay well and to not decompensate. So it's good to start having some templates that telehealth providers put in their notes to support and show CMS that this particular care that's offered through this telehealth avenue, audio only or video, is being done because it's critically necessary and not just out of convenience. So I think that's important. So switching from geographical issues to regulatory issues, though all these are somewhat regulatory, a couple of things to point out. First is that as folks know, during the public health emergency, there was some flexibility about using secure video platforms that may not have been HIPAA compliant and other communications with patients just to keep them well. But that's really ending. We need to get back to using HIPAA compliant secure video platforms, and anything where we're communicating protected or patient health information needs to be in a HIPAA compliant form, and there's going to be more scrutiny of that. So just making sure that everything you're using in terms of seeing patients or communicating with patients and with other caregivers about patients is done through a HIPAA compliant platform, and there's many, many more available now. Another interesting piece is was essentially the in-person telehealth requirements. Now, those have been debated. There was concern about the public health emergency ending and people not being able to see their telehealth provider anymore unless they saw him or her or them in person, which is somewhat odd because we treat people where a provider may be in one state, one part of the country, the patients at another part of the country. The provider is licensed to treat patients there. But this bill essentially would say that within 6 months of seeing that patient through telehealth, you have to see them in person. So how is that supposed to happen? It just seemed kind of odd. And additionally, every 12 months after that, you're supposed to see the provider in person. So there's some misunderstandings about it and some clarification that's needed on behalf of Congress around, one, does it have to be the provider that you're seeing or a provider in that specialty, or working with their primary care provider? Do those providers that you might normally see in person in the town that you live in, does that satisfy the in-person requirement when your telehealth provider, particularly for mental health or substance use disorder treatment, they might not even live anywhere near your town? So will that be allowed? Hopefully, I think so, but at least for 2 more years, that requirement is waived. It's interesting too that in-person requirement, 6 months within starting treatment and every 12 months, is only for a pure mental health condition. And this is what I think really struck me as odd about this regulation. And this is not just part of the Omnibus bill, it's part of previous telehealth bills that have been put forth by Congress. But it's odd because essentially you can do telehealth where you need it if you have a physical health issue. You can do it if you have a substance use disorder. You can do it if you have a mental health and a substance use disorder called comorbid or dual diagnosis. But essentially, these requirements to see your provider in person, your telehealth provider, only applied if you had a pure mental health condition. That seems to go against the grain of fairness and parity that we've come to know in medicine, where physical and behavioral health were seen as equal. So I think some legislative changes to that are going to be coming. The last thing in terms of regulatory issues I'm going to talk about would be stuff related to the Ryan-Haidt Act, or Ryan-Haidt Act, people pronounce it differently. One of the things that's important to keep in mind, the Ryan-Haidt Act is officially called the Ryan-Haidt Online Pharmacy Consumer Protection Act of 2008. So it's been around for 15 years. And it was generally meant to regulate pharmacies, particularly rogue online pharmacies, from filling prescriptions where the doctor couldn't be identified clearly, the location of the provider, the location of the patient, things weren't identified clearly. That's what happened through Ryan-Haidt and why this act became enacted. What we've come to see it to mean is essentially doctors cannot prescribe any controlled substances by telehealth. And that's really a misunderstanding of the intent, I believe, that the DEA had for this. Yet that's the culture in which it's been interpreted. There's been concerns about the public health emergency ending, and then patients not being able to get the medications that have kept them well. And when we're talking about controlled substances, we're talking about pain medicines and buprenorphine, Suboxone, things like that. But we're also talking about other pain medicines that are commonly used, as well as benzodiazepines, as well as stimulant medications that are used to treat ADHD. So all those potentially could have limitations on the prescribing of them through telemedicine, unless certain things are met. Now, there have been exceptions to that all along, and particularly exceptions during the public health emergency. That was one of the main exceptions to the Ryan-Haidt Act. But the in-person requirement is one of the things that was also waived during the public health emergency. You did not have to see somebody in person to have that provider prescribe you a controlled substance. So people with opiate use disorders, as well as people being treated with stimulants for ADHDs and other health conditions for which they're used, and people needing benzodiazepines for panic attack, anxiety, seizures, things like that. They've all been able to get the care through telehealth and kept people well. And that's been critical to their care. So you can't imagine that just stopping. So there's been increased pressure on the DEA to clarify one of the other exceptions to the Ryan-Haidt Act, which is providers that are designated as having a special registration with the DEA. There's a lot of confusion around that and what that actually means. But essentially, what was laid out in the Ryan-Haidt Act is the DEA had a special registration process that allowed providers then to prescribe or e-prescribe controlled substances via telemedicine. So far, though, in the last 13 years, the DEA has never outlined what that special registration process is. Now, I will say, with the public health emergency anticipated to officially end in April, there is more pressure than ever on the DEA to make clear what this special registration process is. Currently, you can go to DEA-registered clinics and hospitals and continue to prescribe through telemedicine for those types of organizations. But there are lots of clinic types and different organizations where patients are, and seeing them through telemedicine and telehealth platforms where some would say that violates the intent of the Ryan-Haidt Act. So we do need some leadership and some clarity from the DEA, which is part of the Department of Justice. And in talking to people around the country right now, everybody's waiting. They hope any day the DEA will come out with stuff. So there's a lot of pressure on them. Presidents, Congress have mandated them to clarify this rule, and yet they failed to do so for 13 years. There are other organizations that are trying to make sure patients get the care they need. So SAMHSA has proposed a rule to permanently allow prescribing providers to offer buprenorphine for opiate use disorders because it's a life-saving treatment, particularly with the opiate epidemic, which is still one of the main epidemics we're facing all over the world. But I would like to see, and I think many patients and providers would like to see the exceptions, not just for buprenorphine, but for everyone with a mental health condition, substance use disorder, who is getting care that may require a controlled substance, that they can continue to stay on that and stay well and not decompensate, not end up back in the hospital or worse. So in reading the pulse of legislators and all for the last 10 years being part of mental health and behavioral health and telehealth, I would say there are a lot of wonderful people that get it, that understand this issue. It's got bipartisan support. Most of the things about expanding telehealth post public health emergency have bipartisan support. But there's some trouble with Congress getting together and passing meaningful legislation right now. So I'm really hopeful that in the next couple of years, we're going to work through some of those roadblocks in Congress and get some of these life-saving measures passed. So in general, the omnibus bill has been very positive, very good for telehealth, very good for mental health. Still some more updates that need to occur, but really moving in the right direction. Thank you for your attention today. If you have any questions, please feel free to reach out to myself or any of us at Iris Telehealth. Thank you.